Thank you, Dr. Saima. It was a nice presentation. The next presenter of the day is Dr. Zahid Jamil from Jinnah Hospital, Lahore. Please come on stage for your presentation.
Assalamu alaikum. I am Dr. Zahid from Jinnah Hospital, Lahore, JAIT, and today I am presenting an interesting case which is a sort of image challenge and one seen, never forgotten case. So I am starting a young female patient with multiple swellings on both elbows. Sorry. So my patient, 28-year female resident of Gujranwala, married, housewife, and having high school education, she presented to us with multiple swellings on the back of both elbows for 1 year. So this is just an image, and we will see it in detail. Patient was in her usual state of health 1 year ago when she noticed development of small swellings on dorsal aspect of both elbows. These swellings were painless, increased in size gradually over 1 year, and caused cosmetic concern to the patient. There was no history of any trauma, fever, joint pains, or weight loss. Patient was having 8-month history of gestation and gained significant weight over this time. Her systemic review for cardiovascular, respiratory, gastrointestinal, rheumatological, neurological symptoms were negative. Her endocrine review regarding hypothyroidism or hyperthyroidism symptoms were negative. There was no history of cold intolerance, fatigue, constipation, voice change. Her past medical and surgical history was unremarkable, and she was not taking any medication other than folic acid for her pregnancy. There was no family history of such swelling, and her parents and siblings were alive and healthy, and there was no history of premature cardiovascular death or chronic cardiac heart disease in family. She was non-smoker, non-alcoholic, with a sedentary lifestyle. On examination, a young female of average build and height with third trimester of gestation, her blood pressure is 120/70. Other vitals were normal. There was no pallor, jaundice, acanthosis nigricans, and thyroid swelling or pedal edema. Local examination of elbow revealed multiple large 3 into 3 centimeter non-tender firm pedunculated swellings on the tuberosities of both elbows as shown in the picture. These swellings were skin colored, mobile with normal temperature and no attachment to underlying bones or tendons. There was no regional lymphadenopathy and elbow movements were normal. This is one swelling on her right elbow, and this is second swelling on her left elbow. On further examination, small peanut-sized swellings were also noted in front of both knees. Her hand examination showed multiple small maculopapular orange-colored skin lesions in the interdigital spaces and in palmar creases, and as shown in figure. There were no other skin lesion noted on face, trunk, or extremities. So here, this picture of her palm and interdigital spaces, and I am pointing. This was palmar stria, palmar planar xanthoma. These are interdigital web spaces xanthomas, and here these are. There were no features of hypothyroidism, Cushing syndrome, or insulin resistance. Her peripheral pulses were normal. There was no corneal ulcus, and both fundi were normal. Rest of cardiovascular, respiratory, and GIT neurological examination was normal. We performed baseline investigation. Her HB, liver profile, blood sugar, especially fasting, thyroid profile, and calcium were normal. Lipid profile was carried out with raised total cholesterol and especially raised combination of VLDL and triglycerides as our lab reports. So case summary, a 28-year-old female with multiple tuberous swellings on elbows, orange palmar creases, and equimolar raised serum cholesterol and triglycerides. She is euthyroid, non-diabetic, and non-obese, and having 8 months of gestation. Diagnosis. On the basis of typical clinical features, equimolar raised cholesterol and triglycerides, and absence of secondary causes of dyslipidemias, my final diagnosis is familial dysbeta-lipoproteinemia. Management of this patient, as patient was having gestation, so most of the lipid-lowering medications were not indicated in this patient. Patient was consulted about dietary modifications, including a low-fat diet, moderate exercise, and appropriate pregnancy weight. Follow-up was planned after gestation for any treatment modification. Literature review. So this slide a bit fade as dyslipidemias mostly fade out of the memory so early. Basically 5 types of dyslipidemias. Hypertriglyceridemia labeled as type 1, type 2, having further 2 subdivisions, hypercholesterolemia and familial combined hyperlipidemia, dysbeta-lipoproteinemias. Our variable of interest in this case is dysbeta-lipoproteinemias, which is characterized by beta fraction of VLDL and cholesterol and triglycerides raised. Familial dysbeta-lipoproteinemia is an autosomal recessive hyperlipidemia type 3 due to apoE-lipoprotein impairing hepatic uptake of remnants of triglyceride-rich lipoproteins. It is a rare disorder of lipid metabolism with estimated prevalence of 1 in 10,000. Family history is usually not present in these cases, and diagnosis is confirmed by genetic testing. Familial dysbeta-lipoproteinemia is important to diagnose because it is associated with early onset CHD and peripheral vascular disease. Modern prevalence of dysbeta-lipoproteinemias is an US study on a large number of population, showing 1.7 to 2% of prevalence for hereditary lipoproteinemia type 3. So typical clinical features include presence of orange-colored palmar stria, and the other differential diagnosis for this palmar stria is cholestasis, and tuberous or tuberoeruptive xanthomas on elbows and knees. Due to recessive nature of disease, a second triggering factor is usually needed to precipitate typical biochemical abnormalities. Usual precipitating factors include obesity, type 2 diabetes, hypothyroidism, beta blockers, thiazide diuretics, or OCPs. Establishing the relation between familial dysbeta-lipoproteinemia and genetic variants in ApoE gene. This is a causal relationship. Familial dysbeta-lipoproteinemia is the second most common monogenic dyslipidemia and is associated with a very high cardiovascular risk due to cholesterol-rich remnants of lipoproteins. It is usually caused by recessive inherited variant of in ApoE gene, E2. But variants with dominant inheritance have also been described. The typical dysbeta-lipoproteinemic phenotype has delayed onset and requires a metabolic hit. Management includes weight reduction by decreasing dietary intake of cholesterol, fat, and alcohol. Drug treatment includes fibrates and niacin in low doses or combination in resistant cases. Some patients respond better to potent reductase inhibitors, and newer therapies and attempt has been made. PCSK9 inhibitors have been described successful in recent studies. A case report of 4 patients, the effect of PCSK9 inhibition in familial dysbeta-lipoproteinemia has been reported, showing PCSK9 inhibitors improve lipid profile in patients with familial dysbeta-lipoproteinemia and may be a treatment option in patients resistant to or intolerant to statins or fibrate therapy. Thank you so much.
Thank you, Zahid. Quick question for all of us. You mentioned about familial hypertriglyceridemia, and obviously this in which both the conditions have high triglycerides.
Yes.
Could you clarify, or could you let us know how would you differentiate if both of them come with the high triglycerides, and if you don't have the genetic testing available in most of the facilities? Is there any history in presentation that can make a difference, and is it any complications which are different among those?
Extreme cases of hypertriglyceridemia are risk factor for acute pancreatitis, and in their history of like chylomicronemias, they present at some stage of their life with pancreatitis episodes.
So would apart from pancreatitis, do you know the pathophysiology why pancreatitis happens in familial hypertriglyceridemia, not so commonly in beta?
In familial hypertriglyceridemias, there is deficient activity of lipoprotein lipase enzymes, and it gets saturated after a certain rise of triglyceride levels. And because in familial hypertriglyceridemias, the enzyme gets saturated early due to an amorphous amount of triglycerides, so they are more prone to develop acute pancreatitis episodes. But the triglycerides do not rise to that much extent because lipoprotein lipase activity is there, but they are having defective clearance of triglycerides due to ApoE protein.
That would be it. Thank you very much.
Thank you, sir.
Describe the management.
Sorry.
How did you manage this? How did you manage this patient?
Our patient was having gestation, so we were with limited number of options. We consulted about her about fat reduction in fat intake and total calories, and also guided about some physical activity to keep the weight appropriate to her pregnancy, and referred to a dietitian for best management of his dietary therapy.
It's in the 8th month, so presumably you would manage something more soon.
It
was the 8th. You said this is the 8th month,
month,
so
yes.
presumably pretty soon you would have had the opportunity to do something more than that.
Yes, ma'am.
What did you do then?
As these, there is a risk factor for coronary artery disease, so I will first treat her for raised cholesterol with a statin, and if the condition didn't improve, and for triglycerides, at the second step I would add fenofibrate.
Thank you.
Thank you, sir.